want to dedicate my remarks today to my father, who passed away yesterday at age 104 years and 11 months. I think he was proud of me. He was an old-fashioned kind of father. We didn't have any participation trophies in our house. You either won or you didn't. I know he didn't know exactly what I did for a living, but I think he was proud of the fact that whatever it was I did for a living, I seemed to do it reasonably well. So I appreciate that thought, and I will, even at that late age, miss him a great deal. One other preliminary remark. When I started to put this talk together about 4 months ago, well, I was raised in the public choice school. Jim Buchanan was my thesis advisor, and one of the most fundamental premises of that school was that, at least at some level, collective decisions get made by taxpayers, kind of like economic man, thinking of, well, here's the benefit from a public good, and here's the incremental tax I'm going to have to pay, and I compare the benefit and the cost, and then I decide which one is the one I prefer. I'm actually allowed to consider not only benefits to myself, but benefits to my family and my fellow citizens and my community, so I don't have to be the selfish economic man. And then that's how I vote, and through some complex process, which of course Arrow has proved never can really work, but we still have faith, those decisions do get translated into actual political actions. Of course, events of the last few months have, I think, mostly I'm just going to ask you for willing suspension of disbelief. I am going to be using a voter model, and hopefully the current period of temporary insanity will pass, and we will return to a world where it still could be huge, but it actually might actually be what the voters want. Ordinarily in a presidential address, as I've observed, don't want to be pejorative or anything, but it's usually a kind of verbal curriculum vitae, and don't worry, I'll get to that. But I wanted to start actually with a policy problem, which will lead to some of those issues. That's the title: should lower income people be allowed to buy insurance with high cost sharing? And here's just a numerical example to give you some sense of what I mean. This is data for somebody with a $30,000 a year annual income. I'm ignoring the technical difficulties, but this is from the Kaiser fund, and the first two sets of lines show you just the basic numbers for gross and silver, where you have a gross premium and then you have a subsidy. The subsidy is $10.90 for both of them. Thank goodness we at least preserve neutral incentives by having neutral subsidies in the ACA, and then by assuming 60% and 70% actuarial value, ignoring loading, I calculated an expected total spending. What you see both at the top and at the bottom is, I think, what most people would probably think of if they looked at those numbers. For this person, $2,500 a month is their income, and probably $2,000 take-home pay. The punchline basically is they're subject to pretty big deductibles. The maximum deductible is $6,850. The average deductible I have down there for the bronze plan is $1,888 and is $1,536 for the silver plan. Of course, it'll be higher than that depending on the distribution of spending, but the punchline is those are pretty hefty deductibles. And as you might imagine, there is, on all of our parts, concern. I think I've said this before, but I should say it again. I am a fan of the Affordable Care Act, in part because it reproduces what I had to say in my PhD thesis, published in 1967, available in antiquarian bookstores under the title Medical Care at Public Expense. But my concern is when the dust clears and we do get back to a kind of more normal political situation, will voter taxpayers really be willing to support the kind of structure of the Affordable Care Act, or will there be pressures to change it? And so what I mostly want to talk about in these remarks is at least what I think are the main considerations that this is a mea culpa talk, so that's why I'm beating my breast, but you should do the same. What we and you should produce in the way of information when we do get challenged on this again, for information to actually help, if not justify the current version of the ACA Act, at least to provide some rough justification for a version that has more than just visceral feelings or round numbers in support of it. So this first side pretty much, I think, tells people what they already know. You've got these two parts for the ACA. I'm obviously talking about the part that has to do with the exchanges. My person there is at 255% of the poverty line, so they just ran out of cost-sharing subsidies. But still, the great majority of the people currently using exchanges have incomes low enough for subsidy, and the great majority of them have chosen bronze and silver plans. I think there's only one person that picked a platinum plan, or maybe three, which exposes them up to, from a couple of thousands up to nearly $7,000 in out-of-pocket payments. And you don't have to be a soft-hearted Republican to worry about that a little bit, that may be a somewhat serious sort of source of concern. People do report going without care because of high out-of-pocket cost. I didn't buy the medical. I would have bought that. These are Commonwealth keeps running these surveys. They all say the same thing. They could just keep running the same survey. We'd never notice the difference. But they all say, with this high out-of-pocket cost, I went without care that otherwise I would have purchased. And I think it's a rhetorical question that's more than just a rhetorical question. Should these low-income people actually be allowed, especially for the bronze plan, to buy policies with such high out-of-pocket payments? And of course, you could offer your own opinion, and I guess I could give you my 2 cents worth too, but the right answer would be it all depends, and it depends ultimately on some empirical information that we don't have that might help us at least to give us some guidance both to us and to those policymakers. Of course, the policymakers hate to be endogenous, and that's kind of what we're trying to do here, but those policymakers we're trying to offer advice to about how to ideally design the structure of the policies that are available in the Affordable Care Act. So it's a source of political concern, and John may know the answer to this. I sent out a graduate student for about 3 months to try to figure out where the numbers from the ACA came from. Mostly she came back and said it looked like they kind of lifted them from Massachusetts and then beat them up a little bit so the CBO would accept them, but as far as I know, they weren't chosen based on any very strong or any behavioral evidence, especially in terms of coverage, perhaps somewhat in terms of the premiums being charged. So these kindly but rational taxpayers may, though, someday ask, what are we getting for our tax dollars? And we're the people who ought to be able to tell them. So that's what this talk is about. Well, what should we want to know if we wanted to be able to tell them everything they need to know about the ideal design for policies for my lower middle income family there in terms of the Affordable Care Act? And I'll make some carping comments about all three of these. One thing we'd like to know is the marginal effectiveness of insurance-induced use on broad measures of health. I'd emphasize insurance-induced use here. This is not just the epidemiologist's boring question of if you give somebody more of something, do they get better or worse? Because I think we have evidence from the Rand experiment in a lot of places that the kind of use that people make greater use of when you change cost sharing is different than just a random assignment to high treatment versus low treatment. And actually, it was charitable for me to write down there mostly weak evidence. We don't have very good evidence. We have, you'll know, I'll get to it, the pretty discouraging evidence from the two randomized controlled trials, Oregon and the original grandfather of them all. Not a whole lot to go on. Epidemiologists do have evidence on small scale impacts of cost sharing. Some of them are kind of getting the message, and what happens if you lower the cost sharing for statins after a heart attack, and what does that do to health outcomes. But what you need to know for policy purposes is what does it do for the broad sweep of a health indicator, not or even a very much more simple version like years of life added, and we don't know that. The impact of insurance coverage on the use of care, that's moral hazard. We do have pretty good estimates here. It's probably the best estimated demand elasticity in all of economics. The demand elasticities, at least as I follow them, have been trending upward, with the 0.2 Rand estimate being the lower bound, and every time somebody else tries it, it gets bigger and bigger. I don't know what that means, but it's interesting observation. So that's the second thing we need to know. And the third thing we need to know is, perhaps the hardest of all, what value do taxpayers place on improved health from better coverage induced by insurance subsidies? A few people have studied this. John Holohan, Tom Graneman, my PhD students. Some people in Europe have studied it, although they've generally asked the question, how much would you be willing to pay for an extra quality adjusted life years as delivered by a public program, not as you would get from your private insurance. But again, it's a pretty sad state of affairs in terms of our knowledge of what the value of life is worth. Part of that's because it's a hard question. Part of it is, if you actually know what the value of a life is worth or even talk about it, no one wants to sit next to you at a dinner party, so we kind of stay away from it. But how could you think about it? This is my contribution from my PhD thesis. It seemed simple to me when I was 26. First, you specify the optimal level of use of each services. Obviously, medical types and wise people must have known that, I thought at the time, foolishly. So, how many people should get a colonoscopy, how frequently, that kind of thing. Then you identify the level of cost sharing for different kinds of people, high-income people, different low-income people, and maybe different racial minorities. But there's some level of cost sharing. There has to be some level of cost sharing, which at least on average will get everybody to hit the ideal level of use. So you say that's the optimal insurance they ought to have. Then you assemble an insurance policy with these levels, and they'll be different for different services. And you both subsidize and mandate it. In both cases, of course, you have to ask the question of the price elasticity of demand for either a positive price or a negative price. But there's some price that would get, again, you can never expect perfection, and there are a few evil Knievels of health insurance out there even now. But you can get at least the great majority of people to buy the ideal insurance that leads them to the ideal coverage, which leads them to consume the ideal level of health care. And so I got my PhD. That's all there is to it. Of course, it isn't quite all there is to it. You have to get the taxpayers to pay the subsidies and the citizens to tolerate an effective mandate and pay the premium. But the mantra is means-tested coverage and means-tested premium. And to my reading, that's what the Affordable Care Act is. So that's why I'm pleased with it. It has the correct qualitative version. Everything's free when you start out at a low income, then your out-of-pocket payment gradually grows. The premium is free when you start out, and the premium gradually grows. That seems to me to be the ideal level of coverage. The main competitor, of course, is Medicare for All, not the Medicare we actually have for all, of course. That's got private stuff in it. But the old Medicare, which we probably won't have, or maybe we will, but the cost of it's pretty high. We might actually have it by having free care for everybody and getting the Canadians to pay for it. Because after all, they're taking our logging and petroleum jobs and sending their sick people across the border to Detroit. So they owe us, but I don't know. I don't think that's too likely to happen. Okay, so here's the first order conditions. I tried to explain these to my dad. The first order conditions. It's for the optimal use of care for any individual. Buchanan thought the right way to think about this is that each individual's use of medical care is a pure public good because we all experience it, even though, of course, the direct user gets more benefit than others, unless it's your 5-year-old, in which case he doesn't see it that way. But that was sort of the idea. There's the direct user's marginal benefit, and then there's the sum of all others' marginal benefits. So. And I am very sensitive, and I think all economists are sensitive to the view that people get utility from other people's consumption, medical care perhaps especially, but also other kinds of things. And that is the first order condition for a pure public good, easy to define, a beast to measure. Here's how you could think of setting it up. I'm way out there. My demand curve, I can't quite read it myself, is D4, the one way out to the right. I'm a well-paid Wharton full professor. I should pay full marginal cost or full insurance premiums because I use so much medical care on my own. I even, clean out my Flex account with designer prescription sunglasses. There are no more externalities, but that DC line, that's the community demand line, that reflects the value that all of us place on each other's. We just drew one DC line here. This is actually a 40-year-old graph, but you could draw it differently for minorities or for younger people or older people or men or women or whatever. And as you can see, when you vertically sum each one of those individual demand curves with the DC line, you do get an optimal user price, and it is inversely related to income. And the quantity of consumption still is not perfectly uniform. It would be if the DC curve was straight up and down, but it brings the quantities much closer together, and that's it. That's what we need to do. All we need is the numbers, and let's do it. Okay. So the key parameters, I think I've said most of these things already, or at least the top ones, the responsive quantities demanded and so forth. But there's a problem here that consumers aren't the only people in the act. They are in things like having to decide whether or not to go to the ER, but once you get into the clutches of the system, physicians come into play, and consumer demand curves may or may not track what clinicians think are true marginal health benefits. You notice I have not said that clinicians are right and consumers are wrong, but at least they have differences of opinion. And clinician views of what are high benefit services may or may not track what impacts health outcomes. I've had some health problems in the fall, and I learned that at a tertiary care medical center, if you don't have an illness sufficient to kill you, they're not that interested in you after a while, I discovered. So how can the poor voter taxpayer know the benefit of lower cost sharing? It's up to us, is the punchline, because there's all this confusion. Okay, well, this I think almost everybody's familiar with and probably doesn't want to read it and get to lunch instead, but we have the RAND study of catastrophic to complete coverage of cost sharing with only a few modest positive health outcomes for most people, large cost reductions for the middle class, reasonable, the part that's sometimes ignored, there was a segment where they looked at ER use, and that was rational. People didn't go in for pharyngitis. They did go in for coughing up blood. But once they were in the doctors' clusters, as everybody knows, they were just as likely to avoid using the care doctors thought was effective as the care that doctors thought was ineffective. The emperor may not be very well dressed in this case, but maybe the doctors are right. In any case, physicians led to confusion. Then, of course, we have the more recent Oregon study of Medicaid for the able-bodied. 25% increase in spending only affects depressive symptoms and large bills compared to insurance. And I think I've said most of the other things. And I need to pay tribute to Amy Finkelstein's work that says these micro estimates are probably all underestimates of what would happen if you change the system as a whole. So when the dust clears, what can we say about what we know so far? The only detectable serious effects of cost sharing on overall health are for low-income people at high initial risk. And no one ever advocated zero insurance to control moral hazard. So take that, John Nyman. It's true that if you had zero insurance, you could get a change in use not associated with moral hazard, but I never thought anybody would rationally advocate zero use. So the income effects, I guess I'm saying, of where we generally are should be much smaller. Cost sharing almost surely causes the rest to avoid care of positive health benefit, but too small to be detected by our insensitive aggregate health measures. It itches. At one point, I had a urinary tract infection, and they wrote me a prescription for an antibiotic. I took the prescription in the evening. It was one of these deals. First, you think you're going to die. Then you're afraid you're not going to die. I felt so terrible. I called back in the morning. Called my primary care doctor, who was a friend, and I said, "Why did you prescribe that?" And he said, "Well, I knew you were a health economist, and that generic was the cheapest one. There were much more expensive ones without side effects, but I thought you'd want to minimize costs." So that's what happened. And I don't know if I minimized cost, but that's what happened. And so there you go. So there's choices to be made there. And you can certainly find in the current pattern of cost sharing when in private insurance and in Medicare. Medicare is worse than private insurance, of course, with no catastrophic coverage. It'd be illegal if it wasn't legal. But the patterns are often not very carefully designed to bring about anything even close to the approximate level of use, such as we know about the approximate level of use. Some of that has to be there because you can't make it so complicated. My wife thinks because I'm in health economics, I should be able to understand explanations of benefits, and I cannot. But there could certainly be, and this is a life's work, I hope, for some of you to try to get more refined design of cost sharing on the demand side, which is what I'm talking about here, and as long as we're talking about it, supply side cost sharing in the form of networks. Both of those are things which empirically, right at the moment, we're in the process of just observing what the heck happens, but at some point maybe we'll actually be able to figure out what's the right thing to do. On the politics of medical insurance, well, I assume our main goal is improved health, but not wealth. Some people have noted in connection with the Oregon experiment that although it didn't do that much for health, it didn't protect them from bankruptcy, but it did protect them from high medical bills. So it may be that the real reason we like health insurance is not because it has anything to do with health. People would be just as healthy with it as without it, but they would be less wealthy. It may be. That's not my visceral feeling. And even if it were, I would point out to you that there are a lot of other insurances like auto insurance and theft insurance, which would then deserve just as much of a subsidy as health insurance, and we got to get Bernie Sanders on that one too. Fire insurance for all. But it may be a concern, and again, it would be interesting to work out a kind of externality story as applied to the after loss, partially insurance covered effects of various kinds of health insurance, and just see what would be the optimal pattern, and as much as we can, what would people prefer. I think that would really be fun to do. Not for me, I'm too old for fun, but for somebody, some of you. Depending on the definition of afford, Kate Bundorf and I and John Gruber both found that at least a third and maybe up to half of uninsureds had income high enough to afford coverage. So it's not just a matter of affordability. We can't afford health insurance. We can't afford care. Just give us money. That's the answer. That's not the whole story. And part of the problem is that because especially of the design of the Affordable Care Act, for certain subsegments of the population, buying insurance coverage at current prices in the exchanges is a terrible deal, and it's not actually young, healthy people because they're mostly covered by subsidies, which means there really is no death spiral for them. They don't care. The insurance is going to be covered anyway. They may be still young, but the wealthy, especially above 400% of the poverty line, are the ones. Maybe we don't care about them. somehow I still care about them. It still bothers me they're running around without health insurance, just like they're running around without pants. That doesn't seem right. So if we only knew the true marginal benefit curves, we could determine the optimal coinsurance. We could determine the probably different value-based coinsurance rates if people were not perfectly informed. If people are perfectly informed, they will choose, at least according to theory, the optimal level of coinsurance and use the optimal level of care. We don't need value-based coinsurance if people knew what they were doing, or if they knew what they were doing and then doctors hadn't so confused them that they no longer know what they were doing. What we do need it, though, when they misestimate the marginal benefit, because then we want to trick the people who underestimate the value of care into buying care by making it look cheaper than it really is, and for people who overestimate the value of giggle products like Viagra, we want to raise the price so they don't buy that, at least not with insurance. But those are the two things that we want to change. It's important to say the value here is not the medical value, it's the net value. So you could have a very highly effective, say, cancer treatment, which could be low value. This is part of my talk yesterday, or tomorrow rather, because it costs so much. Or you could have, I think this was from the old Oregon story, impacted wisdom tooth, which is cheap to fix and adds actually a lot of qualities, but nobody's going to die from an impacted, well, maybe they could get affected, but from a wisdom tooth. And also, incidentally, the level of cost sharing that would apply in the case of value-based cost sharing would be related not to the value of the care, but this is a long article that I will not repeat in Health Economics, but to the dispersion of demand, the diversity of demand, because you basically want to use cost sharing to separate out the people maybe who on average look like they get high benefit from some level of care, but some of them don't. And you want cost sharing to winnow out the people who don't and make sure that the people who do are the ones that actually use it. So we might pray with it would work. The complaints, some people choose insurance with high deductibles. Some choose the cheapest bronze plan just to punch their ticket rather than the more heavily subsidized silver plan, and all complain that they can't afford it. My amateur political economy here is that there's a trade-off. We could reduce the out-of-pocket payment to zero and make the insureds pay for it. All hell would break loose, but that would be a solution. Or we could have the taxpayers pay for it. All hell would break loose, but that would be a solution. But those are the two choices I think we confront if we want to solve this problem. And we do think that the level of cost sharing is too high for low-income people. There will someday be a demand for evidence where you at least can beat somebody over the head by saying, well, if you don't take away that cost sharing, not like the IOM did it with correlations. David Meltzer could deliver a whole lecture on that, but with real causal evidence that this would actually improve health by so much that it would allow us all to go to bed with a clean conscience. I won't say much more about the evidence of benefits, other than to say there's one other little odd end here, that there is a problem with the Affordable Care Act. Nothing is ever perfect. It has a high implicit marginal tax rate. I don't know if Casey Mulligan is here this year to get all upset about that. But the alternative, of course, and this is actually the way the Republican plans are coming out, is have a flat subsidy, but then you have to have a big tax rate to raise the money for the flat subsidy. Optimal taxation problem for you optimal taxation people. Maybe it's been solved. Tell me if it has. If it hasn't, solve it overnight and show it to me tomorrow morning. Conclusions. 1, ACA has a durable and rational qualitative structure, which I think, hope, pray, will survive political slings and arrows, but even getting some quantitative hints to specify and justify the ideal parameters of eligibility, subsidy, and coverage is a gaping hole. And this is something, we know how to do this. We know how to estimate these things. Of course, we need the data, or we need to make it up, but maybe we can get it from all that claims data. We know how to estimate things like the effectiveness of insurance coverage at various levels for large populations in aggregate, and we know how to estimate the effect of insurance coverage, and we even know, if we're willing to take a flyer on it, how to estimate what taxpayers are willing to pay. The Medicare history is not encouraging, but still. Are things getting better? Evidence on some key parameters is getting better, I think. We have improved estimates of cost sharing. Our biggest mea culpa, though, is the evidence of the effect of care on health outcomes. We really need to know that, and I believe it's a scandal that we can say almost nothing with confidence. There are some studies, and actually I guess we're in pretty good shape. Thank goodness that a bunch of the states didn't pass Medicaid, and at least we'll be able, hopefully, to find out the effect of Medicaid coverage on use. God works in mysterious ways sometimes. But then, of course, everybody will have Medicaid coverage after that. But we'll see. And then our biggest challenge, I guess I have two biggest challenges there, is this taxpayer willingness to pay. So my final comments is we're going to need, and my hope is that rather than design one ideal health plan for all of us, they're kind of trying to do that in California. Whoever the smartest people must know the best plan for everybody. I think that's wrong. I think there should be a wide variety of health plans for people with different levels of risk aversion, different dollars per quality that they're willing to pay, and kind of let them pick and choose. And actually, dollars per, if I knew of a health insurance plan which told me we have determined, and think of this in terms of my dad too, when to terminate life based on a value of dollars per quality that coincides with my value, I'd feel much more comfortable about that health plan than the one that says we care, and that's why you ought to buy our health plan. So that's the punchline there. Classify plans by dollars per quality rationing rule, and let consumers take their pick. And then, of course, they won't like this, so it'll be necessary to kill the lawyers in order to have this happen. So thank you very much.